Okay, so as Dr. O'Connor said, when somebody has a difficult behavior, you want to first figure out if there's some medical reason, particularly if there's a change. Looking ear infections, toothaches, headaches, GI issues such as constipation and reflux. Sometimes GI medications for constipation can be irritating or upsetting to feel uncomfortable. Environmental problems, and allergies. Um, Julia, luckily, it was great that she has her lecture before me, so she's already gone through a lot of things about the function of communication, often behaviors for communication. Or if you're trying to uh, escape a task. Okay, and then sometimes we often see in individuals with SLO, if there's a sensory issue, you might see it's individuals some sounds will really bother them, but then they'll want to do the sound themselves again or listen to other sounds, specific sounds. Most people have some sensory difficulties, some sensory uncomfortable, like fingers on a chalkboard in the days when we had chalkboards. There's some of those, and it seems like individuals with SLO and many individuals with autism spectrum have some sound sensitivities. Individuals can be tired and they're just kind of cranky. Like most of us, we get a little bit more tired and cranky toward the end of the day. Individuals with SLO or people who have low tone may be fatigued more easily. Can also have behaviors. The task you're asking them is just beyond their ability to understand what you're doing, or is too physically is difficult. And then change in routine is often very difficult in individuals with SLO. Change in the teacher, change in a room, change in a schedule. We'll often use a picture board or a social. We have different words for it. Sometimes a social story. It can be in a format of pictures on a wall or a book. Someone here told me about the brother. Juki's brother made a lovely social story, had a picture of the airport, picture of the airplane, picture of the hotel here. So his social story, this is what we're going to do. And it also can be helpful if children are perseverative or individuals who are perseverative, where they're asking the same thing over and over. And you just, here's the board, here's the pictures of what we're doing. Or today, this is what we're doing, going to the store, then we're going to so-and-so. So they know. So there's a comfort level. Like most of us, we like to know what our day is going to consist of. Okay, so behaviors that might get better, what I'm going to do is I'm just going to list a couple of behaviors, and I'm going to talk about kind of syndromes or how I think about it, how I try to put behaviors together in my mind because it helps me to better conceptualize what medications and which route might be helpful. But so this is just in general behaviors that might get better: hyperactivity, short attention span, impulsivity, irritability, aggression, tantrums, self-injury, repeating thoughts and behaviors, sleep problems, tics, which are like a motor movement, like can be like eye blinking, movement, or anxiety and depression symptoms. So things that are not usually um, there's always caveats to what I want to say, but so not following directions. That can be from a lot of different things. It can be from inattention, a lot of not following directions, and sometimes in Smith-Lemli-Opitz syndrome is kind of the attention deficit hyperactivity disorder. It's hard to even remember if you have seen other children, typically developing children, ADHD as well. It's, you can tell them one thing is like they don't even hear it; it goes right out really quickly. But flopping behavior. Running behavior, or flopping behavior is if you want the person to do something and they're just sitting down. My meds don't help. Sometimes they can help a little bit that with running behavior. It depends if there's kind of a picture of impulsivity and ADHD that often can have running. We'll do behavioral treatments for elopement. Sometimes if you have a child who has difficulty, they'll elope. Sometimes if they like music and you have a headphone that they're on, but the you have the control and the headphones are there, sometimes they'll stay. Our behavioral psychologists are really good thinking of things that can help. Medicine's slow learning, it can help somewhat if someone's has inattention and they're not learning to their potential, because inattention and overactivity like ADHD, then maybe if the medicine's targeting the ADHD, that can be helpful. Poor social skills, my meds don't help too much with that. Okay. So dangers of self-injury, as Julia already said. So, and you've had lectures. So the back of the eye is called the retina, and that can be detached, meaning it can come loose. And if that happens, if it comes fully loose, you're permanently blind. So we've had so many children on our inpatient unit come to us who are blind or partially blind. So for all of us should know for ourselves as well, because it happens as we get older, and particularly if your eye isn't perfectly round, the bulb, like you need glasses, if you all of a sudden start to see you or your child, like you can't see as well, you have a curtain coming down or a lot of floaters, it's important to, particularly if you see the curtain, floaters are a little bit more normal as we get older, but if there's a big change, to get to an eye emergency room as soon as possible. To have that to reattach. So what we do, we have our patients go for an eye exam, and they'll look to see the back of the eye, the retina. I don't know how our doctors at Hopkins do it, but they can actually get in and do exams. They do know some places will do eye ultrasounds. You still have to be somewhat compliant, but you're not at least looking in, but they can at least look, I think, in the back of the retina somewhat. And then we also worry about a hearing impairment, damaging your hearing from head hits. And we also get, you can get, we get individuals with different, like the ears become malformed, essentially cauliflower ear, we call, or other issues. Okay. So when I talk to someone, I try to conceptualize the behaviors as disorders, because it helps me figure out what intervention I might be able to do. So children with ADHD, children with SLO, particularly individuals who have milder SLO, can be really overactive. Boys have even higher overactivity than girls, but girls can also be overactive. But girls sometimes, like typically developing girls who have ADHD, may have more inattention, where they're just not learning as much, not paying as much attention, while the boys are more noticeable because they're fidgeting, they're jumping around, they're doing more active. So we also I conceptualized, is there a mood disorder? Is there depression? Is there bipolar? I ask about family histories, because often these illnesses can run in families, so it's really important to ask, is there a family history of bipolar disorder, particularly if the doctor wants to start an antidepressant, which can, if you biologically are predisposed to bipolar disorder, you take an antidepressant, it can make you manic and kind of activate the illness. So we want to say, well, wait a minute, and it's really nice, talk to the family and really probe, okay, Uncle so-and-so, tell me a little bit more about him, and try to get that history, because it's just not talked about in families. Is there anxiety disorder? I see a lot of anxiety in individuals with SLOS, including selective mutism. That's where the individuals can speak, and they may speak at home, but they won't speak outside of home. We've had one boy who, he would speak at home, but not at school. He did, I think, in kindergarten, but stopped in first grade. So we were able to treat that. I didn't, but we knew his treatment, and he actually would speak in school. He'd whisper, then it had a tone of whispering, but would speak loud enough whispering. So it became functional, at least. So selective mutism we see a lot. So there's a lot of anxiety in individuals with SLOS. And disruptive behavior disorder, I think of that as more of a description of behavior rather than a biological entity, a biological disorder. And then, so I guess I already mentioned ADHD is common. It can be attention problems, hyperactivity, and I already said this essentially. Oh, so what I didn't say is inattention can be due to sometimes delayed process, or what looks like inattention can be delayed processing time. So individuals with a number of different genetic disorders, sometimes you need to give them a little extra time to answer. They give them a little bit more time until the teachers sometimes wait, and then they'll say it. I don't know if are they overcoming anxiety, or is it just taking longer to process what the person's thinking and find the words to give an answer, or the picture on the communication board. Okay, so depressive disorders. Depressive disorders are really common. 1 in 4 people have major depression sometime during their life. And then there's, you can have maybe it's not full major depression, but it's dysthymia. These are the kind of like depressive realm of disorders. Sometimes it's seasonal. So in the winter, particularly if you're living in further north or further in the southern hemisphere, further south, where you have less light exposure during your winter. Light boxes can be helpful for that, but again, if there's mania, that potentially if somebody, so when people have bipolar disorder, the majority of people, the first episode of that illness presents as depression. And it's only after time, let's see, individuals who we know from individuals who are not treated with meds yet, over time, then the mania shows up. But if you have a depressive disorder and you're treated with a light box, that can induce mania. Exercise, we all know, like exercise, fruits and vegetables, avoiding sugar, and getting good sleep. Those are all very helpful for good mental health, for anxiety, and for mood disorders. Bipolar disorder is also known as manic depression. And all these, I should have mentioned, there are handouts on the tables for all of these slides. And there's something we call disruptive mood dysregulation disorder. This was a diagnosis they invented 10 years ago. Because unfortunately in psychiatric disorders, we don't have any diagnostic blood tests for any disorder that we have. It's really nebulous. We just kind of sit around a table and say, this is what we're going to call it. So they realized, well, we have all these children with these mood disorders. 30 years ago, they said, oh, kids can't be depressed. They're kids, they can't have depression. Right, well, that was wrong. And then they have this DSM, which is kind of a listing of what our diagnostic criteria are, meaning you look at it and they have this, they have 2 of this, that, right? So it didn't match the adults. Children with mood disorders don't look like adults. So they had to come up with something new. What are these children? Sometimes it's just temporary, like during adolescence, but there's a lot of mood instability. So that's a new one called disruptive mood dysregulation disorder. And many people with SLO can have mood disorders. It can just run in families. So you might have an individual who's we have tons of people on an inpatient unit and come to us because they have the very severest self-injury and aggression on our special unit, because they often have they often have a mood disorder as well as whatever their developmental disability is. And then anxiety disorders, so separation, usually anxiety disorders in typically developing individuals, it kind of, throughout our life, they look different. The first disorder that usually happens is separation anxiety disorder. And then you get a little bit older, by age 9 or 10, panic disorder can start there, and generalized anxiety disorder. And selective mutism, I already kind of talked about. And then panic disorder it can happen as well. And I know now there's so much on the internet, on National Institutes of Mental Health, a lot of really good web pages that describe these things. Obsessions and compulsions. So the words in typical language is a little bit different than psychiatric. And then we have 2 different disorders in psychiatry, so it's a little confusing. One is called obsessive compulsive personality disorder. And those are traits, like I have a lot of OC traits, like I want things a specific way, I want to be careful. I mean, it's a really good trait for a doctor to have, because you want to be super careful, you want to go double check it. It might keep me at work a little bit longer than I want, but I get it done. So those are the traits. And then traits in general for all the different kind of personality components get a little bit more milder as you get older. And I've heard some individuals with SLO where they were really doing something when they were younger and not so much as they were getting older. Then there's something called obsessive compulsive disorder, and that's where you do repetitive behaviors. And I definitely see that in SLO as well. I see a little bit of both, and we see that with developmental disabilities, and we're not kind of sure, will a medicine help it? Because is it a trait, which it doesn't usually trait, or is it a disorder? But I definitely have had patients with SLO who, they'll take bottles and dump everything out. Everything has to be dumped out, or opening and closing things, kind of classic obsessive compulsive disorder traits. And sometimes we tend to use the antidepressants. Again, I'm going to talk about those in a little bit. When I go through the meds, I'll go through by disorder, but I wanted to give you a little heads up of how I conceptualize some of these things. So, and then the words in typical language are a little bit different too. So what we say when it's an obsession, it's an intrusive thoughts and it's normal to have these. It's normal to think, I want to just go check that stove once, and that's fine. That's good. I mean, it's, we're dealing with our anxiety, we're dealing with life. It's only if it impairs you or distresses you that we consider it a disorder. Or your spouse, if you really bug your spouse, maybe, okay, so if it's interfering in your relationship, then, it could be a disorder, but so those are normal to have. So the obsession is the thought, and if you actually do the act, that's the compulsion. So that's the medical definition of it. So turning light switches on and off. And yes, we see a lot of these in children with autism who don't have SLO. We don't know why, but these things occur. Okay. All right. And it does seem like I've seen more obsessive compulsive features come out as individuals become older adolescents and adults. I don't know if it's because they have more skills. They're more mobile and they can reach the light switch now, or if it's actually kind of just like in the typical population was going to kick on at that age anyway. Okay. So I always want to emphasize to the families that all medications are trials. It's up to the family to decide. And I'm going to go through real quickly. I'll show you some instruments and the website where to find them that I think that's helpful to look at these. But all meds are trial. Meds they might not help. They may cost a lot. It's a hassle seeing doctors, and you can get side effects that are either nuisance or potentially harmful. Benefits, it may help life function in the family and the child, may help at learning better, it may sleep better, which is critical for both the child's learning and for the family function. And the relationships of everybody might be better. Okay, so Autism Speaks, whether or not a child has autism or developmental disabilities, these are just really nice tools to have. Just Autism Speaks has had some resources and done a great job at putting this stuff on the web. So this is really nice. And again, so my criteria for as a psychiatrist, although I'm biased, right? I'm an MD, I'm a psychiatrist, I prescribe meds. So, but I try to, the way I think about it is there's one of three reasons to do a medicine. Someone's impaired, are they impaired at school? Are they impaired at function? They're not doing the life skills that they'd be able to do otherwise. Are they a danger to themselves or others, such as their eyesight is at risk? Or they're suffering. Maybe a lot of our children with SLO can't express that as much, as opposed to maybe an adult you have who's, has depression and is, is just suffering. And you say, okay, do you want to do it? Try a med. And it's always up to the parent to decide that they see enough benefit with the risk. I tell my parents up front, I'm like, look, it's up to you. But if you want to go off the medicine, please let me know and we'll do it together. We'll do it safely. So this is just, don't read, this isn't on your hand up, but that's okay. This is just in the Autism Speaks, the medication guide. I just wanted to show you that you'll kind of list some things that leaning toward, don't know, or leaning away. And for example, this is the leaning toward. Behavior's not getting better with non-med, behavior's making it more difficult. So it talks about at home, at school, family, outings. So that's in the online on booklet, and the page or two before that, I have it there. It's up there on Autism Speaks. They have about I think 50 toolkit in their toolkit. They have like 50 different files. It's great. They have wonderful things. So they have something to help you. This is what they call a decision guide. So it's just to help you work through, is this something I even want to consider? Because it's nice, think about this ahead of time, and you don't have to be going to a doctor anyway. Just thinking about, what kind of options, and is it something I might want to do? And then these are for, and then they have a component in this area where like, what's important to me as a family, my parents, is it very important, slightly important, or not? It's just a way to work through this, thinking about stress again. Function, it comes down to function at school, function at home, and all of these are in your handout. And then friends, and then are there other reasons for not using medicines that have not been listed? So then they have in a decision aid, they have really good questions because they have questions for the providers. It's kind of 3 steps. One is things to consider ahead of time. Then they're going to have questions for the providers, and then they have a third one that's like when you're at the provider, for the provider to fill out with you, which I'll go over that real briefly. And then what are the target symptoms? How long will it take to work? Just the really great questions that I wish I had always thought of as a physician to actually tell my patients if I'm going to be using a medicine. Blood tests. How long will you decide if the medicine's going to help? And then just more additional, and all of this is on this, so I'm not going to take much time to go over this. So it's all written on your things. And these, but I did want to have it written out. So at least on your handout, you can look at that. And then if you decide it might be helpful, you can go to the website and get the PDF. I think we actually had these I can send them again on I think at one point we had these on the foundation website to download. I'm not sure, but that's something we could probably upload the various tools. I can email them to Gretchen and Kelly. Okay, and then it's really nice because then you can bring this in and say, okay, this is what I have this tool. They said for me to bring it to you as the provider. Let's go over this together, which is really nice. How to give the medicine, a schedule. They have a chart for monitoring side effects, a chart for monitoring the things you're looking at, like Dr. O'Connor said, like let's define it, like head banging, or what's a tantrum, and like say how many tantrums a day, because it is really hard. I do try to say when you're doing medicines, only try to change one thing at a time. Like if you know you're about to change something at school, don't start the medicine right then if you can hold off. So you're only changing one thing, because it is really hard to know. Some of the medicines take a while to work. So you don't know, did something happen at school? Did they have a side effect of the medicine? It's really difficult to know. Okay. And then it has some various tips, low appetite, high appetite, which can be good. And also has some pill swallowing tips. Oh, okay. So this is what I wanted to spend more time on. So I know we've talked a lot about 7-DHC in this conference, and that's what builds up in SLO, because it's the last step. 7-DHC gets converted to cholesterol, and that step is slowed down in SLO. So, a lot of our psychiatry medicines, and some other medicines too, like some antibiotics, can increase 7-DHC. So we don't have any data knowing, like, individuals who have SLO and they're on psychiatry meds, how did it affect their 7-DHC? I don't have any data on that, and I don't think anybody has that. But this is at least and probably taking the medicines, maybe it outweighs, like, the benefit of the medicine is so much better that even if it increased 7-DHC, it might be worth it. But if you're starting out with a new medicine, you're wondering, which one to take. When I have clinicians contact me, I'm like, well, gosh, if they're equal, and I'll try to talk through a bit how I look at it and which medicines. You might as well choose the one that we think that we don't have evidence of it increasing 7-DHC. So I will go through that. So something else that's important, I know I said it earlier, but it was really fast, and I want to explain a little bit more. So So carriers, meaning an individual, a parent who has the trait, or meaning they're carrying one of the genes for that, one of the genes that leads to SLO, meaning that gene means that the enzyme that's affecting SLO isn't working as well. So that would be called a carrier. So some studies, there's a lab, Kara Murnix and the individuals who work with him. So they've looked a bit at some animal studies and some cells from from individuals with with the trait, and found that if the mother is a carrier for SLO, meaning they have one of those genes is impaired, and they are pregnant, the embryo, and they take a medicine that increases 7-DHC, the embryo has effects from that, detrimental effects. Whether that embryo, meaning the unborn child, has, and these weren't people, these were in an animal study. So, but I want to present it because I think it's important. That embryo, that unborn child, can theoretically be affected. This was an animal study, but I'm going to say child because we think if it might happen in adults, right? I'm trying to be, there's not a lot of data on this, but I think it's enough to be cautious. And the authors of this paper recommended that because that child, whether or not that child's going to have SLO, or whether or not that child is going to be a carrier of SLO, can be affected if the mother is taking a medicine that increases 7-DHC. So the authors recommended in the paper that any mother, any woman might be pregnant and who's going to be given a medicine that increases 7-DHC, like a psychiatry medicine, that they ought to be tested to see if they're a carrier. Any questions about that before I go on? Because I know it's the terminology. Yes. Yes. Thank you. Even if you're pregnant with so she asked, even if you're pregnant with a non-SLO child? Yes, exactly. Even if you're pregnant with a child who is not going to have SLO, a child who's not going to be a carrier, or a child who's going to be a carrier of the trait. If the child is a carrier of a trait, they're going to have a higher impairment than if they're not a carrier. I think in their study, they didn't have SLO. But yes, so I think it's really important. So we want to choose, if a woman needs to be on a medicine and may be pregnant, to choose one that doesn't increase 7-DHC as much. Any questions about that? I think that was a good question. Thank you. Okay. All right. So that's where they're talking about prenatal and parental testing. Okay. All right. So the good news is we don't think that any of the meds for ADHD cause increased 7-DHC. So that's really nice. So as a psychiatrist, what I try to do when I conceptualize the disorders and I'm going to choose a medicine, I try to choose a medicine that has the least potential bad side effects. And oh my gosh, I'm been talking too long. Okay. All right. So the stimulants don't increase 7-DHC. I often try those first. We know that in individuals with autism, 50% respond well to Ritalin. That's a double-blind study that we did to methylphenidate. So it's good to try sometimes. It's a really fast trial. If you're going to respond poorly to it, you're going to know pretty quickly often. Your behavior is going to get worse. But it can really give you a nice punch and attention focus, although appetite can be a problem. So, and as you see, I've just written about which capsules can be open and what the liquid form. One of the things that is difficult, though, is that there's a frequent shortage of these medications being made and being able to obtain. So then we can look at the stimulants that don't increase DHC. There's Strattera and viloxazine are both they're actually antidepressants and like an antidepressant family, so they can induce mania. Clonidine and guanfacine, I'd be happy to talk to anybody about these. I've talked with a lot of families about these. They're not in the stimulant class, they're not controlled substances, but they really work quite nicely for anxiety and could be very good for sleep. And I'm sorry I had to miss the sleep lecture. These didn't print, but you can email me and I can send them to you. And also right here, it shows you where the article is. And I'm pretty sure when I went in, and anybody can go in and you can see the tables. What these tables tell you, they can give you the fifth centile for blood pressure. And the children with SLO tend to have high blood pressures. And this is a medicine that actually treats and lowers blood pressure. So it can give you a double benefit. It can lower your blood pressure to a good level, can help your sleep, can help ADHD. It's FDA approved for treatment of attention deficit hyperactivity disorder. These are just the tables. And then antipsychotics, I mentioned, they can do aggression, irritability, tantrums. Because they have more potential side effects, it's not the first medicines that I go to, but it is out of our medicines, it can often treat the more severe behaviors such as self-injury. And we use it for bipolar and schizophrenia as well. So side effects, sleepiness, drooling. Sometimes the sleepiness is good. You give it all at bedtime. You try to kind of work some of these side effects or to your benefits. Most of our meds are long enough lasting. You move it around. You have a hard time sleeping. You give it in the evening. You're agitated during the day. I'm happy to, even if you're working with psychiatrists, to call me, but prior to an appointment, email me. We can set up a time just to talk through the things that are going on and what the meds are, and some strategies that you can then take to your psychiatrist or neurologist. But they do have more potential adverse effects. That's why they basically treat all our psychiatric disorders, but we only use them when we really need to, because you can get a movement disorder that doesn't go away. You can get something called neuroleptic malignant syndrome, which is similar to something that can happen with anesthesia, although that's not more in SLO than other people. And then some of the medicines can increase some of the electrical impulse in the heart. So I've listed, so for each of these, the classes, I've listed maybe the first choice. It doesn't mean, like, I've used risperidone for ages in SLO, and I think it works well. And one study from that group didn't show any change, but another study showed, well, it did increase, the risperidone increased 7-DHC. So I'd say if your child's not yet on a medicine, if you're going to choose one, maybe go for one of the ones of the first choice. But the ones that say that avoid, those are ones that they have shown, the actual studies in this, that there's a decent increase in DHC. So it wouldn't be my first to go to medicine. And also 7-DHC may increase like the burning easily. A lot of our psych meds do that. So I don't know if it's the same mechanism, but it might be. So any medicine that they say, oh, it causes a lot of photosensitivity, and you wonder, could be increasing 7-DHC, but it might be a different mechanism. There are blood tests for antipsychotics. I don't give them routinely, but if I have a child who's on a really high dose and they're not responding and I want to push it higher, sometimes I get a blood level just to see, are they really actually breaking their body, washing it out a lot faster than most people. And then antidepressants treat, although we call it antidepressant, they also treat a lot of, they're actually anti-anxiety, they're anti-OCD. We generally call them antidepressant, but they actually treat all of these different disorders. And then I've listed, first choice would usually be Lexapro. It doesn't interfere with many meds, and it doesn't seem to increase 7-DHC. And then my second choice, and avoiding, now, if your child is doing well, like on trazodone, and sleeping really great. It doesn't mean they need to come off it. It's talking to your doctor and saying, well, it may be the only medicine that works for sleep, and that overrides the concern that it might be increasing 7-DHC. So it's not totally avoid, but it's talk to your doctor, and maybe this is kind of the sequence of meds. And then obsessive compulsive disorder, I've already mentioned that. And then Lexapro is the first choice, kind of avoiding the other ones. And then I've also listed on the handout which meds, the medications that we sometimes use for bipolar disorder, and the pros and cons of them. So, right. And then anxiety disorder, it's the same. It's the same meds. I just kind of listed because that might be the order that sometimes some antidepressants have been shown to work better than others for different disorders, like anxiety versus OCD. So just kind of, I've included them so there's a reference you have in the document. Medications for anxiety that are not antidepressants are often used lorazepam. So I put the usual, the maximum dose. I do lower doses than that. Buspar, I don't think it's helpful for very much anyway in any disorder, but it is shown to increase 7-DHC. And benzodiazepines sometimes, like lorazepam, are also used for seizure disorders. And then the beta blockers, we sometimes use for anxiety, but they increase 7-DHC and I don't usually use them too much anyway. And then some of these the behavioral techniques, distracting, having a favorite toy, kind of routine behavioral, and then the picture board we talked about. And often, so the lorazepam we can use, but also you can talk to your doctor about shifting. Maybe if there's an evening dose, you're going to be flying in a plane, can you give all the evening dose in the morning or an extra dose? Kind of, there's some strategies like that. Sleep problems, you've already had a sleep lecture, and you can read through those. Autism Speaks does have a strategy for sleep. And dental care, you've already had a dental lecture, so, and that's written anyway. And then, so about 50 toolkits, financial guide to individual, and I believe there's also a handout for the safety form. There's a QR code. If you use that QR code by taking a picture with your camera, you'll see, put your camera on it with your smartphone, and you'll see a little yellow thing show up. So my iPhone, you touch on that, and I'll bring you to the website where you're able to get a lot of safety forms of family wandering, elopement, neighbor alert letter, 7 steps to preventing wandering, school alert letter, teaching safety FAQ. So, and that last one had the QR code, which so I'll put it back up because you could do it from where you are right now if you want. Anyway, so that's it. Sorry, rambling on.
That was wonderful. Thank you, Dr. Tierney. Any quick questions before we move to the next speaker? Here's one over here. Thank you.
Do you think that if a child with SLO has a motion sickness, do you think that can cause major behaviors?
I guess it could, yes, sure, if they're uncomfortable. Yeah, it's a good question. All right, thank you.
Thank you, Dr. Tierney. If we were holding this conference 20 years ago, my son Juki would have spent the entire 2 days running at full speed. And that was a big challenge for us, one of many challenges that Dr. Tierney has helped our family with. So I appreciate that. Dr. Dow is here with a talk on understanding and managing sleep disorders in Smith-Lemli-Opitz syndrome. Dr. Mark Dow is a neurologist who graduated from Tufts in 2024 and is currently enrolled in a sleep medicine fellowship at Beth Israel Deaconess Medical Center here in Boston. Ladies and gentlemen, Dr. Mark Dow.